Hotbed Talk.
Hello, I'm George Shorten. I'm absolutely delighted to speak at the EBPOM meeting and at the South of Ireland Anaesthesia Association meeting. I've been challenged with speaking about the future of training in anesthesiology. That's too ambitious. I'm not going to cover that in a 20-minute slot. What I will do, and I hope it's interesting, is share some ideas, some concepts around where I see training in medicine and anesthesiology going in the coming years. So perhaps best to think of it as 4 concepts. I'll set the context. I'll speak a little bit about training program outcomes, and then perhaps the importance of measurement in achieving competence. I'll speak about reflection as a necessary part of what the modern professional should do and should be able to do, a survival technique. And I'll also point to the new discipline of learning analytics as a very likely element of training in the future. Context, much of which you will already know. Modern medical education and training is often dated from the so-called 4 horsemen of Johns Hopkins, the end of the 19th century, Halstead, Welch, Kelly, and Oster. And the basic concept was that those who wish to be physicians, to be doctors, should immerse themselves in the clinical environment. Thus our terms of houseman and resident and so on. And the more time spent in the hospital, initially observing and then helping or participating in care until one had progressed to the point where one was ready for independent practice. That was the model, and it stayed like that for some of the 20th century. The Flexner report in 1910 was important in that it required that the curriculum, such as it was updated as new science and new clinical information came on stream. And perhaps in the 1950s and 1960s, much of medical education and training incorporated some sort of problem-based learning. At the beginning of the 21st century, it was clear that there were problems, that model didn't work anymore. The Lancet Commission pulled no punches. Here, there's a lot of text, but it's a list of problems, and they're pretty inarguable in what the Lancet Commission on the Education of Health Professionals for the 21st century reported in 2010. And there will be familiarity to many of these amongst this audience. A mismatch of competencies to patient and population needs, gender stratification that is persistent with professional status. In other words, not enough women functioning at the high levels of the profession. A narrow technical focus, hospital-based, lack of leadership. But the game changer was patient safety. One estimate in about 45 minutes is that 11 people will have died from medical errors. And you will have read or heard other varying but credible estimates of the amount of preventable harm, the number of medical errors, and the number of adverse events associated with medical error. And whatever the numerator is, however frequent that is, it's too frequent and very substantial. And furthermore, it's pretty clear that our efforts to date across the developed world have been less than successful in lessening that incidence. By my counting, at least 12 countries or jurisdictions produced responsive reports once this became clear. This was the US version. Graduate medical education that meets the nation's health needs. The conclusion was that it needs to become outcome driven. And if that were to happen, that the prerequisite is a greater and more reliable evidence base. So outcome-driven, outcome-based education. And of course, that begs the question as to what this outcome should be. If instead of being based on time, a doctor should be trained towards or to some sort of outcome, what was that? What was the ideal? Some notion that could be characterized of the good doctor, and the United States, the Milestone Project emerged, CanMeds in Canada and the UK and Ireland, some sort of a regulator's version of domains of good professional practice. So that's what the outcome was. Create a pipeline for establishing good doctors. And if the good doctor needed to be described in a more granular fashion, that person should be competent. This is the best definition I know of competence by Epstein and Hundert at the turn of this century. And as you read it, it contains the three critical elements, at least in my mind. One is it's not one thing, it's lots of things. And it's those coexisting. It's an aggregate. So it's knowledge and communication and technical skills and clinical reasoning. Secondly, it's the stuff that would matter to patients, that affects patient outcome or that influences how patients are treated, how they feel, how they react. And then critically, it's not what I'm capable of doing. It's what I do every day, the wet Wednesday afternoon, day after day, daily practice. So that's a high threshold. So I asked you to consider just for today that a training program outcome should not be viewed simply as a static point in time achievement or an event, but rather a hierarchy of patient-focused outcomes at least, starting with very discrete skills. Consider for anesthesiology maybe rigid laryngoscopy, and that at some point during my training I synthesize that skill of laryngoscopy into perhaps an aggregate such as the planning and implementation of anesthesia care for a patient undergoing cardiac anesthesia. And at the point of graduation, I would have accumulated enough of these synthesized skills, what you might call graduate attributes, so that I'm now performing in a manner that aligns to that picture of the good doctor, that I'm a scholar, a leader, a patient advocate, as well as being a clinician. But it might even go further, that the intended outcome of the training program would have some influence on the likelihood that not only do I graduate with those attributes, but that I have a strong likelihood of continuing, first of all, to function within the profession or discipline, and that I do so positively, that I make a positive contribution over a sustained period of time. So those are all potential outcomes, and they're linked clearly. And only if those are linked could we see that my efforts as a first-year trainee to learn to do rigid laryngoscopy eventually translates to some sort of measurable societal benefit. And I might ask you to even consider that the outcomes could be wider than those which are patient-focused. If the training program role is to ensure that societal gain, health gain, then patient-focused outcomes are only part of what it needs to do. If the workforce that results from the training program is to stay healthy, stay participant, stay competent over a prolonged period of time, then the trainee themselves, soon to be independent practitioner, needs to be aware and perhaps trained to look after their own well-being and the well-being of their colleagues. And because of the sheer scale of change in the clinical environment and our various working environments, more than ever, we need to learn how to learn. We need to be adaptive learners. Increasingly, we look at the profession of medicine not as a single continuous career, but as a series of epochs of perhaps 3 to 5 years, during which time I acquire a set of skills or attributes which enable me to function well in a particular scope of practice, in a particular healthcare environment. But I'm also using that time to prepare for my next epoch, when inevitably I will be confronted with new challenges. And in order to do that, to manage that transition from one to another, I need to understand how I learn, I individually learn, how I react to the changing environment. And then thirdly, it would be reasonable to look at the training program outcome as a utility element. In other words, to what extent does this program contribute to the workforce needs that will deliver high quality healthcare into the future? How well does the selection process work? How well do I identify whether or not somebody should progress through that training program? And how consistently do the graduates of that training program continue to be positive contributors throughout a career? Those are all measurable. Currently, we do not measure them, nor do we regard them explicitly as the responsibility of the training program. What would all of this look like? I realize that this is a complex schematic. It's from Van Meel, clever idea as to how training program outcomes can fit within a system with key components that range from healthcare policy to budget to regulator to training body to training program to trainee, and then to the patient and population and back again. Now that's complicated. And within each of those key components, there are a series of interactions that we understand very little at the moment. And so long as we understand them very little, we control them very little. So our efforts concentrated on the training program and achieving perhaps limited outcomes at present are of limited utility in delivering the societal benefit, the health gain, which we hope for and anticipate. Only when this system is enabled by improving our understanding of the relationships between the key components, and when it works coherently as a system, do we suddenly have a series of intervention points. My proposal today is that training program outcomes will be one of those key control nodes within this system. A little more practical, perhaps. I suggest to you that, with the possible exception of the arts, every realm of human endeavor, if it were measured, would demonstrate some form of normal or normal-like distribution. But within medicine and the achievement of medical competence, currently we are bad at measuring. We have some tools of questionable reliability, and their application is far from universal. If I were to ask myself, am I good at this aspect of my job or that, I would be struggling to say whether I perform adequately or well or very well. I would even struggle to say how I compare with my peers. That information is not available to me, and I'm not used to thinking in that way. But if we look at the bottom schematic here, suppose it were possible to establish for just the discrete skills or competences of my job. I'm an anesthesiologist. And that a threshold were established that one could call the proficiency standard or the competence standard. And that on any day, for any period of time, it was possible to measure my performance such that I were either at that standard or above it, and that I became aware of this. And that if I fell short, the elements within which I fell short could be made known to me. It's very difficult to argue that that would not be useful. So how close are we to the measurement of competence, even for discrete skills within medicine? Clearly, there are many types of assessment tool, and we use them regularly. And there are other forms of metrics-based training which are based on measurement of performance. Here's one with which we have some familiarity. I suggest that it holds promise. Proficiency-based progression training pioneered by Professor Anthony Gallagher and others in Yale at the turn of the 20th century, where a skill is identified, it's characterized in great detail, using words for the most part, that these definitions are themselves stress tested, and that the composite, that the series of metrics and errors that make up the skill are examined for construct validity. Do they reliably identify or discriminate between novice and intermediate and expert performance? And if they do, I'm in a strong position. Then I can establish my proficiency standard, a measurable threshold. I can build a training program based on those metrics one by one. And then I can accumulate each of the steps or elements of that skill until I have reached a proficiency standard for that skill. And ideally doing this using deliberate practice in a step-by-step manner in a simulated environment. And at that point, I'm ready to proceed into clinical practice where I continue to monitor my performance through measurement. That sounds a bit theoretical and very elaborate, and it is. We give a practical example. A number of years ago, my colleague, Dr. Srinivasan, did exactly that, just what I described, proficiency-based progression training for doctors who were learning to place epidural catheters in labouring parturients. And the outcome of all those steps was that at the end of that time, the epidural failure rate in our institution for doctors learning to place epidurals in labour halved. It went from about 28% failure rate to about 13% failure rate. And that 28% failure rate is not just a Cork phenomenon, that's fairly representative of other measures of failure rate in novice practitioners. Recently, a systematic review of proficiency-based progression training, the methodology that I've described very briefly there, suggested that compared to other forms, the best alternative other form of training, that this form of training, proficiency-based progression, appears to reduce performance errors by 60%. And quite consistently, it always seems to be between 50 and 60%. Concept number 3, reflection. Reflection tends to switch people off as a vague, woolly notion that either I'm going to do intuitively, or if I'm not doing it, then it doesn't really matter. I suggest that reflection does matter. It may, in fact, represent the difference between those of our colleagues who continue to improve throughout their working lives, in medicine, for example, and those who do not. A recent effort on our part to examine the capacity for reflection across the 60 or so trainees at our institution in Cork revealed some interesting findings, but they were consistent with others. It was that overall our reflective capacity as trainees is intermediate. If there's a scale of 0 to 4, we're in the 2-ish range. But interestingly, reflective capacity seemed to deteriorate as years of exposure to clinical practice and years of medical training progress. Interesting observation. A number of years ago, Dr. Dungalvin, Cooper, Blum, and I suggested a framework for reflection across medicine, but specifically for anesthesiology. How would this actually work? The crucial question, if I am going to become a reflective practitioner, is that going to make me a better doctor? If so, how? Very briefly, here's the framework. The starting point is, in a working environment, am I aware of what's going on around me? Do I direct my attention in a reasonable way? Do I prioritize my attention or focus for one item or element or event versus another? Do I assemble them into patterns that I recognize in an appropriate and timely fashion? Do I know what's going on around me? And if that's the case, moving on to the second rectangle, stage 2, it may be possible for me to identify when something appears abnormal or surprising. And if I reach a point where I recognize something that might be a red flag or an event in evolution, that I'm then in a position to respond to it there and then. If, having been exposed to that event, could be a straightforward enough event in my normal working day. If I deliberately give that some consideration later, when I attempt to extract meaning from it in such a way that I identify or extend my pattern recognition, I build or amend my model of the working world around me, such that I have a greater understanding or alertness. And eventually, stage 4, that I accumulate these new understandings and use them in my practice. In effect, a type of day-to-day experimentation until I reach a point where, for me, an additional piece of my armamentarium has been gathered and kept, and I now not only have it, in other words, I understand it, but I believe in it because I've tried it out. It's effectively self-generated, which is a very powerful motivational tool. I build this into my repertoire or toolbox, and that continues over time. Concept number 4, learning analytics. Learning analytics is a new discipline from the much wider area of data analytics. This is a definition that's widely used: collection and analysis of data about learners and their environments for the purpose of understanding and improving learning outcomes. And in various forms and in various places, learning analytics is being applied to the training of health professionals around the world. In Ireland, we're beginning an initiative which I hope leads to the establishment soon of a national learning analytics unit for health professionals. Where's the opportunity? Well, if one considers 4 changes since 2000, that recognition I mentioned earlier of the depressingly great and recurrent incidence of preventable harm as a result of healthcare, some of which is due to medical error. Healthcare itself leaves a far greater digital trace than previously, and importantly, our training bodies, our training activities is increasingly digitizable. Think workplace-based assessments or e-portfolios, simulation videos, and so on. And clearly, the actual tools, the devices which our data scientist colleagues have accumulated, not just in AI, but in other forms of analysis, are being applied specifically to the process of learning, including self-regulated learning, professional learning, and learning in the workplace. Perhaps healthcare lends itself to this type of application of data analytics simply because it is data rich and complex. How might that actually work? Well, initially, we should start from something explainable, perhaps explainable AI, reasonable objectives. One could, for instance, target very specific patient safety objectives. And in dealing with people and with the risks associated with underperformance, it's essential that the data is accessed and used in an ethical way which respects individuals' privacy, a job of work in itself. I'd recommend Professor Hendrik Graschler, one of our colleagues, delicate framework, delicate being a summary of the elements of the framework. And then we actually build a system that acquires data, that identifies data streams, and that puts in place some form of analysis of the data that's generated in a sensible way that produces actionable outputs for individual trainees, for training programs, or indeed for the risk environment itself. That then is piloted, and the pilot effort, perhaps in a trust, a hospital, a group of hospitals, in such a way that its value is evaluated. Once a successful pilot is established, then it is built in to the institutional practice. That might seem a little bit theoretical. Let me give an example. Within Ireland, of the 13 big categories of patient risk, medication error is one. Consider that the specific target is inappropriate prescribing of NOACs in the perioperative period within a particular hospital group. Data streams identified from the operating theatre suites within that hospital group, analytics applied for those actionable outputs, such that the doctors, nurses, pharmacists, and others involved in the care in the setting where that risk we know occurs are trained just in time in a customized manner that is individualized to their specific strengths and weaknesses. This training is delivered, and the outcome or impact in terms of adverse events or near misses is collected. Thank you for your attention. I went over my 20 minutes. 4 conclusions. Outcome-based training is necessary. We need to redefine outcomes such that we're not looking at the training program in isolation, but using a systems-based approach. And for now, because of the deficit of empiric evidence, we must use logic to look at the interactions between key components. We need to develop training programs, courses, and methodology that includes measurement. It's becoming increasingly important that we acquire the ability to be adaptive learners. This requires reflection. And I propose to you that learning analytics will be a useful tool, not in the decade ahead, but in the years ahead. Thank you very much for your attention.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.